I went ahead to start the recording, Julie, just to make sure we're all working and so forth.
Okay.
We'll wait as long as you feel comfortable waiting for people to arrive.
All right. Yeah, it's just now approaching 2, so we're fine.
Okay. You just let me know when you want to begin.
Here we go. I know. Yeah, we thought about like a Muslim woman who doesn't have these, They're still adding. I see people are still joining in. Should we wait another minute or so?
Your call. I have 3 attendees on right now, as well as you and I and Dr. Shaw.
Okay. Well, we'll go ahead and start then.
I will do that. Hold on. Okay, you're in charge now, Julie.
All right. Thank you very much, Jeannie.
Okay. Welcome everybody to this webinar presented by Dr. Pam Shaw and Julie Max from University of Kansas. This is a presentation that was given at the ASPE conference in June in Las Vegas, and we've asked them to do an encore. And we ask that you don't put your phone on hold because we can hear your hold music. If you need to go, you can sign out and sign back in. Other than that, Julie has indicated that she is happy to take questions throughout the presentation. So thank you very much, Julie and Dr. Shaw, and thank you, and we can start the presentation.
Well, good afternoon. I'm Dr. Pam Shaw. I'm a pediatrician and I'm the medical director of the Clinical Skills Lab. It's the NICE Clinical Skills Lab. We're NICE here in the University of Kansas, so it's actually named after our benefactor, but I'm going to try to move the slides along now, and they're not moving, so.
Now, that doesn't make us happy, does it?
No. No, I'm not getting any movement here.
Okay, I'm working on it, madam. I should try to reload.
Oh, no, we're okay. We figured it out.
All right.
We don't hit enter. I've listed some learning objectives here, but really what I'm going to cover is kind of the background of what we present to our medical students and what they have before they come to the Clinical Skills Lab and actually do the event that we have. And Julie's going to do the most important, what actually happens when they get here and some of the background for that. So I'm going to just go over some of the background on cultural competence. And this slide just talks about how cultural competence can be achieved. There are many ways of doing it, but of course the way that we choose to look at some cultural competences, observation using SP patients with some formative feedback. Obviously, you can do it with real patients. That takes a lot of faculty time, and what we, of course, found is that using the clinical skills lab during the second year of medical school is an effective way of doing this for our students. There's been a lot of national efforts on cultural competency. Obviously, it's one of the competencies that students and residents have to show as far as ACGME is concerned. So there's been lots and lots of work on what cultural competence is, as well as training for physicians and other healthcare providers in this area. This is just one of the many kinds of definitions there is for cultural competency, and I like it because it's fairly short. And it's from the HHS Office of Minority Health from 1989, so it's been around a long time. But it really goes over behaviors, attitudes, and policies in a system that enables effective cross-cultural exchange. The culture itself is a pattern of human behavior, such as language, customs, values, and institutions of racial, ethnic, and religious groups. And then, of course, competence. What does that mean if you're culturally competent is the capacity to function effectively within this context and of beliefs, behaviors, and needs. The definition of cultural competence is culture is defined as patterns of human behavior inherent. There's lots of examples, and we always think about things like different kinds of racial patterns, but really it can be as simple as a religious difference or a social group difference. I always like the generational difference because we often talk about our learners being a different kind of learners, and we have to take that into consideration, but we also have to take that into consideration when we're seeing our patients and what they expect. Many of our geriatric patients expect a different kind of professionalism than what many of our medical students see or do with younger patients, and so that's important in the context of culture that we're dealing with. The behaviors include thoughts, language, customs, beliefs, and institutions, and it's affected obviously by immigration, family structure, the education of the family, and the socioeconomic status. At the level of an individual provider, though, it's defined as a set of academic and interpersonal skills that allow individuals to increase their understanding and appreciation. The key is the understanding of the differences between groups. Culture is shaped by many things, and this is a really nice article by Carrillo in the Annals of Internal Medicine, and what she has put is different categories of what culture is shaped by: age, gender, ethnicity, education, religious beliefs, sexual preference, and collective experience. And I encourage you, if you haven't read this article, it's a really nice synopsis from medicine. So go over each of those areas. Language is important because the members of a cultural group communicate with each other through a common language. There are many words for snow in the Inuits because snow is so important in their culture. So it's important to know about culture and how that language. There's a lot of mistranslation. This is one of my favorite things. There was a coffee creamer in Japan which was very popular, known as Creep. I wonder why it wasn't very popular in America. Anybody would want to put some Creep in their coffee. The other one is a Super Piss, which was a car lock de-icer in Finland. It didn't work very well in this country, but that was the mistranslation that happened. In Latin America, the Chevy Nova was introduced, but in Latin America, Nova means something different. It means it doesn't run. So it was under those circumstances that we obviously did not do well with the Chevy Nova in Latin America. In an Anglo culture, looking away shows a lack of respect for a speaker. That's what many of us are used to. But in the Native American culture and many Asian cultures, looking away means you are respectful of the speaker. So it's important to draw those distinctions away. One of my favorite pictures. Not different from them, but different like them. So we could all point to people who we think act a little different than we do. The American medical system is a culture, and it's important that the students understand that up front, that the way they talk, the way they act is a culture in and of itself, and that patients don't necessarily understand or know why physicians act the way that they do. There are a lot of world cultures as well that are different than what they perhaps have been raised in an American culture, where the group supersedes the individual. There's a deference to hierarchy, and there's some etiquette rules, and of course you always think about how you approach a family and the hierarchy of a family. There are nonverbal cues and indirect messages, and of course the key is that one size does not fit all. You have to continue to learn with each of the culture groups that you deal with. It's important also to think about time perception, and I found this out in my own practice with the Latino culture that I deal with, that clocks and calendar time are a little different to many of the families I deal with. I live with my Palm Pilot and my group-wise agendas, and I know to keep to a schedule to a certain extent, whereas many of my families don't live in that kind of world, and they don't have a black book that keeps all of their appointments, and for them it's very difficult to keep on time. And there's a real difference to them on time as to what they do and what I do. There's more of an emphasis on involvement of people and completion of transactions in the Anglo culture than in any other culture as well. So it's important to draw those distinctions with your patients when you're dealing with them one-on-one and time. In the American medical system, we are very future-oriented. We talk about preventive medicine. We're enthused about new technology and drugs. We're always exploring and trying to find new advances in medicine, whereas patients are very present-oriented. They almost always will follow a course of treatment only if they're symptomatic. In other words, if you tell them they have high blood pressure but they're not feeling bad, they may or may not comply with the medication if they don't feel that the medication is necessary. They also can discontinue medical treatment if they perceive that there are side effects because at this time they're not feeling good, so they're not going to take it. And they're very concerned with day-to-day substance rather than worrying about whether this medicine is going to help their cholesterol, which will then prevent a heart attack in the future. They're very much more concerned about whether that medicine causes them any side effects or not. There's also a difference in the cause of disease and belief systems, and we believe obviously in the germ theory as scientists in medicine, but in many cultures there's a lot of other beliefs which are very important to them as well. Of course, most people are familiar with if the spirit catches you, you fall down, and some of the Asian beliefs about things like epilepsy or seizures. So it's important to know what is important to your patient in the belief. If they don't believe that germs cause disease, then washing their hands is not an important part of taking care of themselves or others. So those are all important in a culture system that you need to be aware of. So medicine is a culture, as I mentioned before. We have our own language, and we spend a lot of time with the students talking to them about jargon and not using jargon with patients. So it is important that they understand that when they talk to each other, they're using a certain kind of language that's not necessarily appropriate for a patient. We have customs as well. Why do we do certain things that we do? Why do we do listening to the heart in the way that we do? There is some medical obviously knowledge behind it, but some of it is also customs, and it's important sometimes to explain that. And beliefs, I think most people understand that we talk about when there's a full moon, the ER is going to be real busy, and we're a very superstitious lot, even though we're supposedly very scientific. There are some barriers to healthcare that are involved in culture that we need to be aware of, most obvious one being poverty. Education also as well, because it's important not only to know how to read all of those handouts that we give, but also the pill bottles and so forth. So both of those are barriers, and they also impact on our ability to care for patients from other cultures. Access is a huge problem. Transportation and physical disability. Being able to come to the doctor when your doctor's appointment is depends on a lot of things going in the right way at the right time. And the last one, language. If you don't speak the same language as the provider, that can be a difficulty that obviously we're going to talk about a little bit with our SP that we use. Modesty is another one. Of course, in the Muslim culture, there's a great deal of modesty. In fact, many women choose not to see male providers, if at all possible, because of the cultural mores in that culture. Also, the medical decision-making authority The individual who's involved may not be empowered to make decisions regarding care, and there's, of course, many stories about that where you must speak to the male head of the household to be able to make a decision about someone who is ill, who, in our culture, it's very important that we share this information with the patient and get their understanding, and in other cultures, that is not the way that it's done. So it's very important to make that clear as to how those medical decisions are going to be made from the very outset. So why is cultural competence, and what should you know to have a successful cross-cultural encounter? The big things are the things that we talk about with all of our students, of course, is that they need to be aware of the diversity that's out there, respect those differences, use empathy, and perhaps maybe we don't emphasize this as much, but curiosity as to what those cultures are and understanding them is probably one of the most important pieces that we need to make sure that the students have. So every patient encounter is a cross-cultural encounter, whether you're talking to a young child or an older adult. It's different than what you are as a provider, then it's a different cultural encounter. I'm going to talk about interpreters real quick. One of the things that we provide the students is not only this lecture that I have gone over with you, but also some rules about using an interpreter. It's always best to use a trained medical interpreter, and in most healthcare settings, it's required that the medical interpreter be trained. There are some standards that have been published. In 2001, was published by the U.S. Department of Health and Human Services that there are standards that everyone who is an interpreter has to fulfill for them to be a qualified medical interpreter, which is not the same as just speaking the same language. It is required then for all recipients of federal funds, either Medicare or Medicaid, that they use an interpreter who has been classified. We often get into difficulties with this because we have resident physicians, medical students, and nurses who may speak Spanish or the language of the patient, but if they're not qualified medical interpreters, should they be interpreting for the healthcare provider who doesn't speak those languages? And that's an interesting question. Using an interpreter. Triad placement. Interpreter is assigned not between you and the patient. Speak to the patient, not the interpreter, and that's sometimes difficult to do, but it is important that the patient be the focus of the encounter and not the interpreter. Using appropriate lay language and then speak clearly in a normal voice. And this is probably the most difficult thing that I have when I'm using an interpreter, because I tend to speak louder as if the interpreter can't hear me, rather than speaking clearly in a normal voice. So have to watch that. The 4 C's to ask when you're dealing with someone who doesn't speak the same language. What do you call your condition? It's important to know that up front. What do you think caused your condition? How do you cope with your condition? And what concerns do you have regarding this condition? So the 4 C's are the things we tell the students they need to remember when they're asking. And then the most important question, of course, is tell me about yourself. There are a lot of mnemonics out there as far as dealing with cultural competency, but this is one I like because it deals with, when you're dealing with medical students, it's nice to say, I want you to learn. So this is the mnemonic that I use for their lecture, is listening actively with respect, listing the health beliefs of the patient, assessing their priorities, values, and supports, recommending a plan of action with adequate explanation and understanding, and negotiating by involving the patient in the next steps. So first, with listing, appropriate greetings to everyone in the room. Is there an interpreter in the room? Using their open-ended questions to start the encounter. Avoid interruption. And this is difficult sometimes. You need to speak in small phrases, if at all possible, so the interpreter can interpret correctly, and also ask a question in a very pointed way, such as, could you please tell me your reason for the visit today, or how can I help you today? Then you elicit the patient's perspective. What worries you the most? Are you afraid that you might have something serious? What do you think caused your problem? And obviously all of these questions are nice questions to ask for eliciting the patient's perspective, and then you hopefully will get a response from the patient that the interpreter can give back to you easily. medicine in the U.S. can be foreign to many people. They're used to another type of medical care, so it's important that you explain the way the medical system works. Sometimes that takes more time than anything. But one thing that I always like to talk about as far as finding out more about their support system is I'd like to get to know you more today. Could you tell me more about yourself, or what brought you here to this country? Always ask about their control over the environment. Sometimes, especially if they're new to this country, they may not have much control over where they live or what they're doing, and it may be more difficult for them to make changes in their environment, such as smoking, et cetera, things that we talk about with them. Social stressors and support network is important. And last but not least, literacy and language. Always ask first, before you give them a handout, ask them if they understand the language that you're handing it to them in. Recommending a plan of action. To make sure that we understand one another, can you tell me what it is that I explained to you? I call this talk back, so that the patient tells me what I just told them, and often it's not exactly what I told them. I'll tell you a little story real quick, because I love stories. That I had a wonderful little Hispanic family. Dad spoke fairly good English. We did not use an interpreter for the encounter, and his child had an ear infection, and I gave them a prescription for amoxicillin, which is an oral medicine. When I told them how to use the prescription, I told them it was for the ear infection and for the ear pain. So they came back in 2 days because the ear pain was not better, and Dad had been putting the medicine in the child's ear because that's what he heard to do with the medicine, because that was for the ear pain. So I learned a valuable lesson about making sure I explain things very well and that they explain back to me what they heard with that patient encounter. In negotiating involving your learn, what are your ideas about what should happen next? Making sure that the patient knows that they're involved in both what has happened in the context and also what will happen in the future. So, take-home lessons. Cultural competence improves medical practice through self-reflection. You learn about a patient's culture from that culture, and the community has the expertise that you need. Always use your community, because that's where the patient is coming from.
Okay, and I'm Julie Mack. I'm the Director of Standardized Patients here at KU. So what role can we play? How can we train medical students to be more culturally aware as related to patient care? Well, we can do what we do best. We can present standardized patient simulations. We've had a program here at KU for about the last 5 years. The case name is called Pablo Rios. It's a 65-year-old Hispanic male, comes in with a cough. I have this cough that never seems to go away. It's the chief complaint. Mr. Rios speaks little to no English, so an office assistant, and in this case, in our program, not a trained interpreter, translates for him. This is targeted, as Pam said, to our second-year medical student. It's in their curriculum of infectious disease. So we're using 2 standardized patients in each room here, 1 patient and 1 interpreter. So we ran it that way for about 2 years, and then we found that there were a lot of students who were fluent in Spanish, and so we thought, how can we give them the same experience as their colleagues? So we decided to add another language. We chose Chinese, and we named him Quinlin Lee. This is the same case fact with an adjusted patient profile. So the students then must communicate with Mr. Rios or Mr. Lee through the interpreter to complete the encounter. Just to describe our logistical details just a little bit, these are 30-minute encounters. We have then 5 minutes afterwards for feedback from the standardized patient's care. The students then have 15 minutes to write a note. We have 180 students in the second year, so we run usually 6 rounds per day over 5 days, using about 6 rooms each day. We hire 7 pairs of standardized patients, 6 Spanish pair, 1 Chinese pair. This allows for 1 pair on break each round and creates a backup pair, just, in case something happens. We all know about those little things. 15-minute break for all built into the middle of the rounds to sort of keep everybody fresh. We have the standardized patient in a gown on the exam table. The interpreter is in street clothes and is purposely placed, and this is real important, we purposely placed the interpreter off to the side, way almost in the corner, away from the exam table. We want to see, will the student bring them closer together for better communication, for that triangle that Pam referred to. We do have an orientation for students, as we do for all of our programs, sort of explaining why they're here today, what they're going to do. And here's where we make the determination as to what room to send them to, because we ask if anyone is fluent in Spanish or Chinese. When we get a student who says, yes, I am fluent, then we will send them to the Chinese pair. Just helps us to sort of run it that way, we found, the easiest way to do it. We tell them about a chart. We do have charts. We ask them to speak only English during the encounter, so it forces them to interact with the interpreter. And we tell them there'll be feedback. We tell them they're either going to examine Pablo Rios or Quinlan Lee in the preceptor's office. Neither patient speaks English, so you have to enlist the help of an office assistant to interpret for you. You may wish to clarify your expectations beforehand. Please do a full history, focus PE, take notes in your chart. You have 20 minutes. So that's the basic student orientation. Our standardized patient checklist is divided into interpersonal communication skills, history taking, physical exam, management, and professionalism. Student scores are derived, of course, from the checklist. Our lowest scoring students receive feedback from Dr. Shaw. Concerning the feedback, we have basically we set it up to have a 5-minute positive discussion, open-ended questions. Did the student use open-ended questions for the chief complaint in the history? How did the student ensure patients' concerns were fully addressed through the interpreter? How did the student feel about working with an interpreter? And how did the student show they were working effectively with the interpreter? Expectations, positioning, those sorts of things. And really, most importantly, were there lines of communication open during the encounter that installed trust in the examination room? Did the student ask about family? Did they get a conversation going about how long the family's been in the country? Whether those sorts of things. Did I, as a patient, feel comfortable sharing my story? The standardized patient and the interpreter lead the feedback as a team. They do revert to their real name. And they use language such as Pablo or as Quinlan Lee, I felt, and start the discussion this way. And they normally ask the students the very first thing. They use an open-ended question, so how is it that you felt about this encounter? As far as pre-encounter learning, before they come here to the lab, they have a lecture in the fall on cultural competency that Dr. Shaw spoke of. We do post information for students. There's a document called Cultural Competency in Working with Interpreters, some guidelines for how to use an interpreter. Pam has put this together for the students, and we do post that for them to look at. We do have WebSC here at KU. It's very valuable to us. Obviously, we have scheduling components and recording data. Allows us to grade our post-encounter note. Grade skill reports, video review, targeted video review for student feedback if we feel it necessary. And we have them provide us, fill out a satisfaction questionnaire for us on all of the programs. I wanted to talk about recruiting here a little bit. It was sort of the tricky part to getting this all going. We need to know how many standardized patients. We figured it out with our student numbers. We now have a good roster now of Pablos and Spanish interpreters. Recruiting of new or additional SPs is mainly through word of mouth and referrals from current SPs. But at the beginning, when we first started the program, we really went down a couple of different avenues that were very valuable to us. We approached some of the Hispanic churches in our area, some of the community centers, some of the more authentic Mexican restaurants, and we did some networking in the Kansas City Hispanic community. And that enabled us to get the roster of Pablos that we needed to begin this program 5 years ago. When we wanted to add the Chinese component, we went in a similar direction, although we did find a Chinese faculty member who recommended a friend whose father could play the patient role, and that person suggested an interpreter, a friend of his. We would use the same resources as we did last year because we were not able to use that pair again. So we would use the same resources. We seek out Chinese faculty again, go to the Cultural Affairs Department at the university. Hospital Interpretive Services is a good source. Again, community network and authentic restaurants. We have a standardized patient who is fluent in Spanish. That was extremely valuable, again, to us at the beginning, and he is still involved in the program, and that is something I would very highly suggest that you try to find. If you don't have a staff member here, maybe one of your standardized patients is fluent in Spanish. We used him not only to help us recruit, we sent him out in the field at those places that I talked about, but he was also the trainer for the event and is still involved in training the event. This is very helpful in crossing cultural barriers, this language issue. Our Chinese interpreter speaks English very well and was able to assist us in training. Again, very important to have one of those. It's okay if the Chinese standardized patient perhaps doesn't speak English, but you really do need to get that interpreter that speaks English also. Training, obviously key to any successful standardized patient event. The Spanish and Chinese SP interpreter teams are trained separately. Spanish SPs and interpreters train together as a group. Since there are 12, we split them into two different training days. There were too many to train in one room. Interpreters need to know the role just as well as the standardized patient. Role training sessions in addition to feedback training sessions. We had both. We had I think we more or less had 3 hours for role training, perhaps more if they were new to the case, and at least 3 hours in feedback training. Were led by our standardized patient trainer who also assisted with feedback training.
Julie, can I ask a question, please? Hi, this is Carol. Just on that last slide, as far as you were talking about training separately, you just had a few adjectives in there, and I wanted to just understand. So when you said that you trained the Spanish and the Chinese, and then you had SP/interpreters separately,
we trained them in pairs.
The Spanish interpreter and SP together.
Right, and the Chinese, since we had one pair, what I meant was that we trained that Chinese pair on the Hispanic group.
Okay.
Does that make sense?
It does. Thank you.
Yes, okay. During the event, we found it very helpful because we were running 6 rooms at a time, and we had 12 standardized patients, 2 monitors, one for the standardized patients, guiding them from room to room, and one for the students. Lots of hand-holding of the SP, especially at the beginning. It has more or less gotten easier because we have been able to use standardized patients who've done the program from year to year, so that does make it more helpful, of course. The standardized patients and the interpreters are not always paired together for the entire event. The Chinese pair, of course, is because there are only one pair, but the others we kind of like to mix up a little bit, pair them with different people. It tends to keep the program fresh. And it also allows for our standardized patients to take breaks for us to tweak performances if we feel it necessary. We're watching live, so we may need to pull an interpreter and maybe adjust something, or pull a standardized patient and adjust something and pair them with someone else.
I have another question. So when you said you have 2 monitors, are they both in the room, or one in the room and one outside?
So when I say monitor for us, that term means they're in the hallway.
Person. Okay, and is that a person, or is that a computer monitor?
They're people. Yeah, I have staff members, our coordinators act as actual monitors in the hallway, assisting students, making sure the charts are taken, making sure the student is logged in correctly to our system.
Okay, thank you.
This next slide, this is Pam again. This next slide is we're going to deal with a little bit of competencies again, and this slide has to deal with what the AAMC has out there as far as a tool. And this is a tool for assessing your cultural competency training that's in your curriculum right now. It is an assessment tool. So if you download it and you look at it, what you're going to be filling out is what is available in your curriculum now. It permits you to identify some gaps and identify the strengths or the things that you're doing well right now. And it does meet the LCME goals of ED21 and ED22 having to do with cultural competency and LCME for anybody who's doing reviews. So it's a nice tool to use. I deal with data because it's one of the things you can do to improve programs. And so this is data that's available from the questionnaires that we do with our students. And the question that we give to the students is, how well do you feel you can elicit cultural beliefs from patients? And this is data from the last 3 years that is up here now, 2008, 2009, and 2010. and it's a 1 to 5 scale, as you can see, and most of our students feel fairly confident that they are able to elicit cultural beliefs from patients. This is actually data that's taken from the GQ, which is the graduation questionnaire for all medical students across the country. And in red is the percentages from all schools as an average, and this is percentage from our school, KU, 2007 and 2008. So they are doing a lot of experience related to minorities and to disparities and how many of them have been involved with that. We have a large amount of students who are involved in underserved and minority care. And as you can see, the percentage has grown over time. I included from 04 in here, but even in just 5 years, you can see that 58% of our students have some type of experience related to cultural awareness. So, which is really good. It's been steady over the last 2 years, and it appears to be greater than what they're seeing average-wise across the country. Also, our students are working in the communities. This is working with community-based multicultural groups, and again, about 34% of them are participating here, a little higher than what is done nationally. This is one of the things that I think is always interesting. What we ask the students, do they think that their instruction on culturally appropriate care for diverse populations is inadequate, appropriate, or excessive? And inadequate is the blue percentage. So there's still about 18% of the students, about 12% of our students who think that their instruction is inadequate. 83% think that it's adequate. And then we have a small percentage that think we're doing too much, which I really appreciate. I'd rather be more think we're doing too much than not enough. And this is also an important slide that I like, that they do believe, at least compared to national, that they are prepared to care for patients from diverse backgrounds, and their average rating was 4.5, which is pretty good on a scale of 5.
Okay, so after the encounters, we had standardized patient performance assessments that we have for each of our cases that our trainer fills out while they're observing live. We have staff team meetings afterwards to determine the positives and negatives of the program. Grading of PEMS happens. We talk about changes in training and feedback. We talk about changing the standardized patient encounter for next year, whether we'll use certain people, whether they worked or not for us. And actually, to talk about maybe what we're going to do next year, we have found actually that we have students who were last year fluent in both Chinese and Spanish. So we thought, all right, we'll take on this challenge. So this year we're going to add, we looked at our population of what surrounds and what surrounds us, who comes to our clinic, and we decided to add a Vietnamese pair. We have a contact here on staff who thinks she can get us a standardized patient and an interpreter, and so we're going to mix it up just a little bit more. So we'll be asking the students in orientation, are there people students who speak Spanish fluently, or Chinese, or Vietnamese in this case, and so we can continue to give our students the same experience. We've listed some web resources here for you that would be valuable to you or possibly to your students. Also some books that Dr. Shaw has put in here, and her references. This was a quote that Pam felt would be good to share with everybody. It is much more important to know what sort of a patient has a disease than what sort of disease a patient has. William Osborne. So I guess now that concludes our slide presentation. So we'd like to open it up for questions from the group.
This is Carol again. I had a question about what do you think is, I would say, kind of the cutting edge or the frontier, kind of the next thing to be figured out?
As far as presenting our program or cultural competency in general?
I'd say cultural competency in general, related to medical students.
I think looking at something different than language is going to be very important, because I think most people do have programs dealing with how to deal with interpreters and how to deal with people who speak a different language, and obviously the federal government has some, I hate to use the word mandates, but they are mandates as to what you're supposed to do with folks who speak different languages. The crux of what I see people struggling with now is, number one, health literacy, how to deal with folks who have different sets of health literacy, and then number two, just issues having to deal with culture itself, not only with adherence to medication, but also I think with how their culture affects their disease or affects basically their medical care. So those are the areas that I think are going to be things that we're going to be challenged to try to present to the students, because it's what happens in real life.
I'll keep going with questions if no one else has any.
Absolutely.
When you did do this with the groups, you had 6 different SPs, and I'm sorry, now I don't remember if you had multiple different cases. So was that all that was?
The background information for the case were made culturally appropriate for the Chinese here and the Hispanic here. But essentially it's the same case. It's the same chief complaint, the same history.
Did you have other events, other cases going on the same day, so that a student would see someone who was of an American culture and then someone of a Spanish culture?
No, we have multiple programs for them in the first and second year, and in our third year clerkship, where they're exposed to different cultures and to different chief complaints, different diseases. We are using this as a tool to assist us with cultural competency in the second year. About mid-second year is when it happens. So they only come to the lab to see this program on that day.
And do you have a way of working with the students for them to become more aware of their own culture and kind of like what's really some of the hidden types of things to appreciate themselves, to then understand the depths of other people?
We do a lot of programs where we ask the students actually to self-assess, to watch their performance with patients, not only with cultural issues, but really issues in general, which I think is probably the most valuable piece. And in fact, I'm doing some literature review and some comparison of their self-assessments and the way that we assess them, and how different those actually sometimes are, especially in areas of interpersonal communication. They often think they're communicating very well when in fact they really aren't to the patient's level. So I think that's one of the major things that we see. But we do ask them to self-assess, which I think is that piece that they really need to learn how to do, because as a physician they'll be doing that for the rest of their life. As part of their reaccreditation for their boards, they have to actually do self-assessment and reflection on their performances.
Carol, if you'd like, I could send you this case.
Yeah, so I'd be interested in that.
Okay. Do you have an email address you can give me?
Yes. So it's my first 5 letters of my last name, so F as in Frank, L-E-I-S, and then C, at, and then it's MMC, it stands for Maine Medical Center, .org.
Okay, I'd be glad to send it to you.
And then other times, these presentations have been available on the ASCII website. Will that be true for this one?
Yes.
Great. So
on the ASCII website, there will be a link. When our new website's available, there will be a link that you can go into, and you can go right to this presentation.
Great. Thank you.
Any other questions?
This is not a question, but more kind of a comment of something that we're doing here. This is Liz Oley in Newfoundland, Canada. And we've set up what has to be the most labor-intensive ST trainer activity in the universe, but it is bringing in people who are themselves recent refugees. And so we have the translation issues.
we in our facility here, we're a pretty homogeneous population, so we do not have accredited translation facilities or people in very many different languages. And so there are the issues of having someone who's a family member or a stranger, but someone who's of a small, similar cultural mix within our community who is then gaining access to very personal information about patients or its children of the refugees themselves that are serving as the translators. So these are very real issues that people face when they go to the doctor. So what we have set up is more of that kind of translation experience in hopes that this is with first-year medical students and with communication skills. They're not only looking at the complexity of translation when you're not really convinced that your translator even understands completely what's being
trial by fire here a little bit, huh?
What's that?
A little bit of trial by fire here.
Well, yeah, and so the students are they're getting a very real experience. And then the other thing is looking at, because it's refugees or new immigrants, looking at what are the adaptation and adjustment issues so that the cases that the refugees bring to the encounter are your typical kind of somatic PTSD issues, be it not sleeping, stomach problems, headaches, that type of thing. And so they're using a combination of either their own experiences or experiences that would be similar to people from their culture.
I see.
So it's labor intensive because it is working with each pair individually to create a story that's safe for them to tell and not bringing up painful issues for them.
How many pairs?
These are facilitated sessions with physicians and social workers as well as medical students.
Okay.
This is Carol with another question.
Uh-huh.
The FPs that portrayed the non-English speaking patients, what was their usual range of English proficiency?
Most spoke pretty good, I would say all of them spoke English pretty well. Walter, do we have a few that, we might have had a few that spoke more or less broken English. But for the most part, we were able to find in our community patients who were bilingual.
And then did they speak up during the feedback time?
Yes, both speak up and both act as a team in the feedback.
Great.
There are some that don't speak any English, and they continue to use the interpreter during feedback. We do ask that they do give feedback as the patient, how they felt, because many times, one of the major things we see, at least with the interpreter and the medical student and the patient, is that the student will start talking to the interpreter instead of to the patient. And it's important that the patient tell the medical student during that encounter how that made them feel.
Right.
Yeah.
So your bilingual patients, do you have them not speaking English, though, during the encounter?
Yes.
They're pretending they don't speak any English?
Yes. That's true.
Okay, thanks.
Anyone else?
And one thing that one of our lead trainers was remarking on, that sometimes the SP acts more natural if they actually can't speak English, and sometimes it adds a little bit of reality to the encounter if they really can't speak English, because they are indeed in the position where they don't understand what the student is saying.
And again, since you have as long as you have the interpreters that are bilingual, you can do that if you'd like, if you want to. Cast only non-English speaking Spanish patients.
It seems, though, to me that disadvantages of that outweigh the advantages. That, as far as the feedback and training and all of that.
Right. And we have a mixed bag, I think.
Right.
It is complex, though, to train someone who is an English speaker to pretend they don't know English. We find that the hardest thing in our training is for people, because they naturally do respond, and their whole nonverbal is with some understanding. And so training that out of them back to a non-English speaking behavior is tricky as well.
Right. So it depends whether you're going for the authenticity or going for the ultimate communication with the student.
And how big your recruiting pool is, too.
Yeah.
I mean, yeah.
One of the things I wanted to add is that we're going to be expanding our cultural competency program benefits of a grant from our culture enhancement and diversity staff here, and so we're going to be doing some new programs in the clerkships and also in the residency programs here, the primary care residency programs, and expanding not only what we're able to teach them didactically, but also the experiences that they're going to have. So if those of you are on the phone have experience with doing other cases and you'd love to share those with us, we'd love to share our case with you and vice versa.
I'll be starting some at the end of April and running them April and May, and my intention is to also have people who are deaf and possibly blind and add that to the mix.
Yeah, that certainly is a different avenue that we haven't gone in that could be very valuable to students.
We do deaf and also a blind scenario as well.
And is that Liz?
Yes, this is Liz.
Okay, great.
This is Janie. We also do a deaf scenario. We have not done a blind scenario, but our deaf one works very well.
Excellent.
Any other questions or thoughts?
My thoughts are thank you. This was very helpful and nice to have a group to talk about this with.
Thanks for participating.
Yeah, appreciate the topic. It's very timely for us.
Yeah, I really enjoyed your presentation, Dr. Shaw and Julia. Thank you so much. I appreciate it.
You're welcome.
Everyone for attending.
We more interactive.
But we had some videos.
Janie?
Oh, I'm here.
Thank you.
You're welcome. Thank you.
You're welcome. All right. We'll talk to you later then.
Bye-bye.
Bye.
This is what we like to do.